So we have covered the CVS. Now we are going to start the neonatology from pediatric subject. The first topic that we will be discussing is birth asphyxia. So we are having a scenario that there is a full-term baby who was born by normal spontaneous vaginal delivery in a well-equipped hospital. At birth, he had central cyanosis, gasping respiration, heart rate 80 per minute, some flexion of the limbs on stimulation, and facial grimace on suction of secretions from the mouth. So, what is the problem of the baby? What is the Apgar score? Name 5 variables which can be assessed by score, and what are the important steps to save this baby. Birth asphyxia. Asphyxia means lack of oxygen and blood flow to the brain. Birth asphyxia happens when baby's brain and other organs do not get enough oxygen and nutrients before, during, or risk right after birth. The risk factors for birth asphyxia are both maternal, placental, and fetal. In maternal, we are having hypertension, eclampsia, and preeclampsia, pelvic abnormality, diabetes mellitus, nephritis, hypotension, infections, uterine tetany, and maternal hypoxia. In the fetal, we are having cord prolapse or compression, abnormal lie or presentation, post maturity, anemia, infections, cerebral abnormalities, hypoxia due to pulmonary or cardiac problems. In placental risk factors, we are having abruptio placenta, placental insufficiency due to toxemia or post maturity. Now, the investigation options for birth asphyxia are before and after birth. Before birth, we will do the check for the signs of fetal distress, for late bradycardia, for decelerations, and for sustained tachycardia on cardiotachograph. After birth, we will look for the depression in Apgar score, and Apgar of 3 or less prolonged for more than 5 minutes gives the diagnosis of asphyxia. So this is the Apgar score. For A is appearance, that is skin color. For P is pulse, that is heart rate. For G is grimace, that is response to the stimulus. For E is activity, that is muscle tone. For R is respiratory effort. So, if the color is blue or pale, then the points will be 0. If the color is body pink, is extremities are blue, then the point is 1. And if it is fully pink, then the points are 2. Now, if the pulse is absent, then 0 points. If pulse is below 100, then 1 point. And if it is over 100, then 2 points. If there is no response to stimulation, then 0 points. If facial grimace is present, then 1 point. And if the babies cry, then 2 points. For activity, if the baby is flaccid, then 0 point. If do some flexion, then 1 point. And if normal with movements, then 2 points. For respiratory rate, if it is absent, then 0 point. If gasping is present, then 1 point. And if it is regular, then 2 points. So the normal score is from 7 to 10 points. And from 4 to 6 score is very low. And less than 3 is critically low. So these are the Apgar score for birth asphyxia. Now the complications of birth asphyxia are CNS complications, that is hypoxic ischemic encephalopathy, then kidney complications which are acute tubular necrosis, then respiratory complications which are respiratory distress syndrome, meconium aspiration, and apnea, then GIT problems which are necrotizing enterocolitis. Now the management options for birth asphyxia are both general and specific. The general managements are nurse baby in thermoneutral environment, then record vital signs and maintain input-output record, then pass NG tube and respirate the stomach, avoid hypoglycemia or hyperglycemia by regular glucose monitoring, then measure blood gases, then treat the hypoxia with O2 4 liter per minute and hypercarbia with they treat acidosis with judicious use of the soda bicarbonate, maintain fluid and electrolyte balance, and review the infection risks. The specific measurement for the birth asphyxia are for CNS, for CVS, for renal, for pulmonary, and for GI. For CNS, seizure should be treated, that is phenobarbital is given. The treatment of cerebral edema is done, that is fluid restriction and careful monitoring and electrolyte treatment by using hypertonic solutions like 20% mannitol. For CVS, hypotension and cardiac failure is treated with plasma and inotropic support, and cardiac failure is treated with digoxin and inotropic support. Renal support is done by measuring the urine output more than 1 ml per kg per hour. Pulmonary treatment is done for apnea and CO2 requisitions, meconium aspiration, tracheal suctioning, and pulmonary hypertension. Inhaled NO, increased oro, and pulmonary vasodilators are given. For GI necrotizing enterocolitis, antibiotics are given and avoid enteral feeds, correct hypoglycemia, hypocalcemia, and hypomagnesemia. So we have discussed the first topic from neonatology, that is birth asphyxia. We have discussed the scenario that what was the scene. There was spontaneous vaginal delivery, and at birth he had central cyanosis, gasping respiration, and heart rate 80 per minute, some flexion of the limbs on stimulation, and facial grimace on the suction of secretions was present. So, what is the definition of birth asphyxia? Then, what are the risk factors of birth asphyxia? These are both maternal, fetal, and placental risk factors. Then, we have discussed the investigation options, which are both the before and after birth. Then, we have discussed the Apgar score. Then, we have discussed the complications, that is the CNS, kidney, and respiratory and GID complications. Then we have discussed the management options, which is both general and specific. Now coming towards the next topic, that is respiratory distress syndrome. Okay. We are having a scenario that there is a baby born at gestation of 28 weeks and develops tachypnea, grunting, chest retraction, and cyanosis soon after birth. How will you define this baby according to his gestation, and what problem has he developed? So, what is the latest treatment and how it is given? The diagnosis is respiratory distress syndrome, and the definition is that respiratory rate greater than 60 per minute with significant chest indrawing caused by lack of surfactants, most frequently in preterm infants. Okay, what is respiratory distress syndrome? It is a respiratory rate greater than 60 per minute with significant chest indrawing, and it is respiratory distress caused by lack of surfactants, most frequently in preterm infants. Now, what are the causes of respiratory distress syndrome? These are lung disorders due to aspiration, that is pneumonia, meconium aspiration, and milk aspiration. Then delay in the clearance of lung liquid, which is transient tachypnea of the newborn. Then disorder due to lung immaturity, that is idiopathic respiratory distress syndrome, bronchopulmonary dysplasia, and pulmonary hemorrhage, apneic attacks, and air leaks like pneumothorax. Then the congenital malformation, that is diaphragmatic hernia, bilateral choanal atresia, and tracheoesophageal fistula. Then the extrapulmonary causes, which are cerebral anorexia, intracranial hemorrhage, hypothermia, hypoglycemia, anemia, polycythemia, metabolic acidosis, persistent pulmonary hypertension, cardiac failure, and congenital heart disease. These are the causes of respiratory distress syndrome. Now, what are the differential diagnoses? These are congenital pneumonia, aspiration pneumonia, meconium aspiration, pneumothorax, then diaphragmatic hernia, cardiac failure, cyanotic heart disease, and transient tachypnea of the newborn. These are the main causes of the respiratory distress syndrome, and these are the differential diagnoses of the respiratory distress syndrome. Now, the investigation options for respiratory distress syndrome are chest X-ray, that is evidence of pleural effusion, pneumothorax, atelectasis, emphysema, or cardiomegaly is present. Then septic screen is done, which is complete blood counts and blood, urine, and CSF culture to rule out the early onset of the sepsis. Then arterial blood gases is done, which is the evidence which gives the evidence of hypoxia and acidosis. Then pulse oximetry is done, which monitor the oxygen saturation. Then hyperoxia test is done to differentiate between the cardiac and pulmonary etiology in infants who have cyanosis. Then blood sugar and calcium levels are checked, and then ECG is done to rule out the congenital heart disease and pulmonary hypertension. Now, coming towards the management options of respiratory distress syndrome, we are having both the general supportive management and the specific management, and then we will discuss the complications. So, in the general management, maintain neutral thermal environment, and then keep careful monitoring of the fluid and electrolytes, especially prevent hypoglycemia. Maximal handling of the baby is done. Hold feeding till baby stabilize. Keep input and output record, and carefully monitor auto saturation. Keep blood pressure normal by plasma extenders and fluids. Treat the metabolic acidosis by giving soda bicarbonate 1 to 2 ml per kg. Now, the specific measures are warm humidified OT is given, CPAP is done, IPPV, that is intermittent positive pressure ventilation, is required. Surfactant replacement therapy is done. And how surfactants it's given? Surfactants should be given in those units where full neonatal intensive care facilities with ventilators are available. Dose is 100 mg per kg, administered through endotracheal tube, and repeat if necessary 6 to 12 hours interval. While administering, infant should be disconnected from ventilator and ventilation through umbilical should be continued for at least 30 seconds with 100% oxygen. Complications of the surfactant therapy are endotracheal blockage, pneumothorax and pulmonary hemorrhage, and ventilator setting monitored carefully. The complications of RDS are patent ductus arteriosus, intraventricular hemorrhage, pulmonary complications, that is pneumothorax, bronchopulmonary dysplasia, pneumonia, and the complications of mechanical ventilation. These are the complications of the acute respiratory distress syndrome. So we have discussed the respiratory distress syndrome. We have discussed the scenario for it. Then what is the definition? Then we discussed the causes, which are lung disease disorder due to aspiration, delay in the clearance of lung liquid, then disorder due to lung immaturity, then congenital malformation, extrapulmonary causes. Then we have discussed the differential diagnosis. Then we have discussed the investigations, which are chest X-ray, septic screen, arterial blood gases, pulse oximetry, hyperoxia test, blood sugar and calcium level, and ECG. Then we have discussed the different management options, which are general supportive care and specific. And then we will discuss the complications of RDS. In the next video, we will discuss the next topic, that is neonatal sepsis and jaundice neonatal. Thanks for watching.